Good afternoon, good evening, and thanks for this opportunity to share with you some reflections from India on advancing publicness and regulating commercialization of health systems, some of the lessons that we have tried to learn from the COVID pandemic in India. In India, we had a very high number of COVID-related deaths. Actually, they were the largest number of such deaths in the world compared to any other country if we go by the WHO estimates. Almost 4.7 million COVID-related excess deaths. And within India, the state of Maharashtra had the maximum number of deaths. And not only that, but it also had a very high case fatality rate from COVID. As you can see here. So Maharashtra is a large state of India. It's the second largest state of India population wise. And here we had almost 150,000 COVID deaths. In that sense, Maharashtra was the worst affected state in India during the COVID pandemic. So because of this situation, and because of the high level of privatization of healthcare in Maharashtra, the struggle to ensure healthcare for COVID patients was really acute. And this led to a whole range of innovative public actions, public health actions, both from above and below. Here you can see people begging for hospital beds and begging for oxygen. And because of this situation, these public actions emerged at the interface between the three major components of the health system: the public health system, the private healthcare sector, and people. So at the interface between public health services and people, we saw a whole range of initiatives for co-production of health. At the interface between private sector and people, we saw the whole discourse and actions on social accountability of private hospitals. And in the interaction between public health system and private healthcare, we saw interventionist regulation of private healthcare and certain modified public-private healthcare arrangements, which emerged in a very innovative way during the COVID pandemic. So first of all, participatory initiatives for co-production of health. Basically, in the COVID pandemic, on one hand, we had seen a whole range of very centralized government actions, including lockdowns, various kinds of quarantine, isolation, testing, and so on, directives coming up. But at the same time, we had a lot of participatory initiatives also coming up from the ground. And these involved not just the public health services, but elected leaders, frontline health workers, grassroots activists, social groups. And these collaborated with the health system in a unique range of public-public partnerships, which were quite unique. And this is what we call a co-production of health, which appeared spontaneously during COVID. Health cannot be produced only by the health system or only by communities, but together they can, produce a much better, delivery of health services. And so this is one major area. And an example of this was the whole civil society run help desks in a whole range of public hospitals across Maharashtra. SATHI, the civil society organization which I work with, actually ran help desks in 40 public hospitals across the state, where more than 80,000 patients and caregivers were actually, guided to access healthcare. So this is a close collaboration between civil society and the public health system, which emerged. The second major area is, of course, social accountability of private hospitals because of the whole area of overcharging and violation of patients' rights. So we saw this entire campaign which emerged. We started with a state-level hybrid public hearing with more than 130 participants, where 30 patient testimonies on private sector violations were actually presented on overcharging, on denial of free care under various government schemes, violation of basic patients' rights, like detaining the dead body of a patient to extort money. And SATHI came out with a publication called Patient Voices During the Pandemic to document and analyze these violations. So the part of this social accountability was conducting a survey, a participatory survey of more than 2,500 COVID widows, women who had lost their partners to COVID and other family members. And they were asked how much they had to actually spend compared to the government regulated rates for COVID care. And it emerged that 75%, a very huge number, had to actually spend more than 10,000 rupees per day on hospitalization care, which was significantly above the regulated rates for COVID care. And this led to an organization of anger assemblies in some parts of the state, where COVID widows and other people, they came and shared their experiences of gross overcharging. And this led to the government decision to conduct a participatory audit of all the overcharging complaints in Maharashtra. So something like nearly 500 such complaints were submitted, and there was a civil society state collaboration to actually audit each and every of these bills and look at each item in the bill and how whether it was in accordance with the rate regulation or whether it was in excess. And this led to a refund of excess charge rates from private hospitals to 63 COVID patient families, if the average amount of refund was more than rupees 25,000 per patient. And many more also got informal refunds from private hospitals. So that was the second front. The third front is interventionist regulation of private healthcare. So basically, because of the whole inadequate public health capacity, the government realized that there's a looming market disaster which is coming up in the COVID situation if the private hospitals are not appropriately regulated. So Maharashtra was the first state in India where the regulation took place of COVID rates of COVID treatment and also for non-COVID treatment. And 80% of the beds in all private hospitals were brought under rate regulation. This is the highest proportion compared to any other Indian state. And this was quite unprecedented because until now, the government had not really effectively regulated private hospitals. So there's a shift from what you can call minimalist regulation to interventionist regulation, where actually the pandemic played an important role. A fourth area is basically, as I mentioned, that in the COVID first wave, many private hospitals shut down, refused to treat COVID patients. In the second wave, they started overcharging. So these are all manifestations of market failure. And therefore, the government had to step in to check this market failure. And they reconfigured and expanded the existing public-private arrangements. So the major health insurance scheme, which covered only the poor sections of the population before COVID, was universalized to cover the entire population during COVID. And also 80% of beds in private hospitals were closely monitored so that they would provide effective treatment to COVID patients. So these new kind of healthcare arrangements, public-private healthcare arrangements, shifted the balance towards market reshaping arrangements, not just market streamlining arrangements. So this was a new kind of phenomenon that we saw in terms of public engagement with private healthcare. So coming back to these three major sectors, if we see what is the dominant trend and what is the new new kind of direction that has emerged during COVID. In the public health system, as we know, in India, a very centralized kind of decision-making process, all concentrated at the top, and very little leeway for frontline workers. Compared to that, in COVID, we saw this co-production of health and new kinds of social collaborations, upgraded status of frontline workers coming on the agenda, and an expanded role of the public health sector. Similarly, regarding private healthcare, we know that privatization and very minimal kind of regulation has been the dominant theme. But during COVID, we saw, as distinct from this, interventionist regulation being activated and new kinds of public-centered arrangements with private providers. And similarly, regarding private hospitals dealing with patients, very common commercialized practices, overcharging, irrational care. This was countered during the COVID epidemic by social accountability of private hospitals emerging on the agenda and patients' rights. So all these three areas, which you can see with the boxes with red borders, these three can be combined under a single kind of theme, and that is advancing publicness of health systems. So finally, if we see how we need to move in the post-COVID situation towards a new politics of health, we need to convert COVID's very tough lessons into building blocks for health system change. And reinvention of social solidarity, building upon the kind of social solidarity which emerged during COVID to strengthen public health. Then recognizing the indispensable role of frontline health workers, nurses, ASHAs, frontline doctors, and building collaborations with them and ensuring that they are given proper working conditions and compensation. Expanding the notion of public itself. Public is not just the government system, it's also a whole range of public actors who got activated during COVID. So we need to keep that expanded framework of public in mind, which can definitely lead to strengthening of public health services, using the framework of co-production to rejuvenate health services, especially at the primary healthcare level. It's very much feasible. Challenging privatization of public hospitals and health services, which I have already mentioned. And also, as we saw, mobilization of medical victims, people who are impacted by the commercialized care in private hospitals who were overcharged or who had other kinds of violations of rights. Now we are seeing an entire discourse on patients' rights emerging in Maharashtra and demands for implementation of patients' rights. And then also leveraging the social embeddedness of non-public providers. The providers, the smaller and not-for-profit hospitals, they need to be treated in a somewhat different way. And we have to think about how to bring them under a larger social umbrella of universal health care. And on the other hand, corporatization and super profiteering definitely needs to be checked. We cannot treat the entire private healthcare sector as a single homogeneous entity. This differentiation needs to be kept in mind. And these are some of the steps which we can take for advancing publicness and regulating commercialization as we develop a system for universal healthcare, where basically the public health system is expanded, strengthened, improved, and made more socially accountable. And the private healthcare sector is regulated, effectively regulated, and brought under a larger public logic. So I conclude with two quotations. The first is that the mind, once it is stretched by a new idea, it never returns to its original dimensions. And in the COVID situation, we have seen these new ideas emerging. So now we need to not go back to business as normal as it was before COVID, but rather to take forward these insights and these lessons for health system change. And the second quote is from Paul Farmer, who has said that we find ourselves at a crossroads. Healthcare can either be considered a commodity to be sold, or it can be considered as a basic social right. It cannot be comfortably considered both of these at the same time. So there's a choice that needs to be made. And that choice is the choice of health systems today, which is there before all people. And we need to make that choice of advancing publicness and regulating commercialization of healthcare as the key lesson which emerges from the COVID pandemic. And in all its complexity and all its different dimensions, this is something that probably some of the lessons that you can draw from India and Maharashtra from the COVID pandemic. Thank you.